Hi guys, great session. Question to Sheng. The iris spatula technique for the MINIject, I've started using it and I certainly think it leads to a more or less traumatic insertion. Do you think sometimes if the size of the cleft either side of the MINIject is quite small, it may lead to more likelihood of fibrosis and scarring, as opposed to, obviously you don't want a large cleft, but having a bit of a cleft either side? Do you think that's a positive predictive outcome of a good IOP?
Yeah, that's is unknown, because they are looking at the size of the cleft surrounding the implant in the FDA trial at the moment. So far, it's very difficult to correlate between the size of the cleft versus the efficacy of the treatment. But you're right, by having a small cleft beside the implant, you might get closure very quick early on and get an IOP spike. But what we are hoping is that the implant itself is being porous. There will be aqueous flowing through that. So maybe it's a real challenge to the implant to see, hey, does it actually flow through the implant? Or is it relying on artificial cleft or iatrogenic cleft that you created during the implantation? No way of knowing, but yeah, it's a good point.
Just a quick one on that, Sheng. Do you think injecting a heavy viscoelastic or maybe a anti-clotting agent would be of use?
To prevent
early fibrosis?
I don't think so. I think at the end of the day, fibrosis is a slow, progressive thing. I mean, you could change it by injecting some viscoelastic at the short term, but that's going to wash out within a couple of days. Likewise, at any injections of TPA, that's going to last for a day. So I don't think in the long term, it's not going to affect the long-term outcome of the implant. That is my belief.
I have a question for Philip Bloom. Regarding the cyclophotocoagulation, well, I remember you published an article several years ago that was on cyclophotocoagulation ab externo. And I must say that despite the pretty good results that you had there has been this aura of bad press on cyclophotocoagulation, both ab externo and ab interno, for the danger of phthisis and also for loss of vision. So could you briefly sort of clarify where it stands regarding the real danger of having severe decrease of vision due to the procedure itself, and whether the micropulse has, in your opinion, drastically changed that?
Yes, of course, thank you. I think you're referring to the series we published in the 90s, about 210 transscleral cases, and that was the very first cases done at Moorfields when I started to do my fellowship at that stage. And yes, they were much more advanced eyes. Many of them were NPL-eyes. Treatment was being done for pain control. So it was a very heterogeneous group of patients. We've become much more refined now about the place for transscleral. Now, I personally believe there is a place for transscleral cyclophotocoagulation. In my hands, both continuous wave and micropulse, but also endoscopic. But I would actually barely regard endoscopic cyclophotocoagulation as a cyclodestructive procedure. I tried to popularize the term cyclomodulation, but it never caught on because it's not known. Some of that ciliary epithelium that you treat very gently may regenerate, maybe not in a secretive capacity, maybe. But you don't risk doing the same damage to, for example, the ciliary vessels and the ciliary nerves, which can have quite an effect on the anterior segment. It's a much more targeted, gentle procedure. And yes, we're moving away from the continuous wave thermal cyclodiode as well in favor of micropulse, which again has certainly an effect on aqueous production and perhaps also on uveoscleral outflow. There's evidence to suggest that it may actually make the ciliary body more transmissible to fluid. And so again, that has a dual method of action, which I think is always useful. We're used to regarding drop therapy, both in terms of inflow and outflow, and I think it's rather unidimensional to only think about MIGS devices as outflow devices. I think if you can combine it with some effect on inflow, be that by ciliary body separation or by cyclophotocoagulation, I think that's very beneficial. We rarely see visual loss after ECP. We do sometimes see it with inappropriate case selection after the transscleral treatments. And sometimes that's due to CMO, cystoid macular edema. Sometimes it's due to progression of the condition. You know, it's as has been said, failure of the treatment is actually a complication. And that can often lead to adverse events themselves. But for those who haven't tried endoscopic cyclophotocoagulation, it is a safe treatment. It's a very safe treatment, obviously with the caveats that you have to apply treatment appropriately. And it is also efficacious in the same way that other MIGS procedures. And I also believe that it has a place more in advanced disease as well. So I think it's a very useful device to have around. But as a long answer to your question, we rarely see sight loss after ECP. We do sometimes see it after cyclophotocoagulation, but then these are very advanced end-stage eyes.
If I could just add quickly, I think that's a great explanation. I think in the U.S., we're using transscleral laser a lot in patients who have tube shunts with inadequate IOP control, and I think it's a really nice place. We had a trial comparing that versus second tubes, and the results were a little underwhelming. But I would say that I think a half treatment with transscleral laser, you could do ECP, Brian Francis has published on it, is really nice for your patients who have an omet or a Barebelt who are just not right where they need to be. And again, these patients have good visual acuity and end up with very fine vision. I feel like that's one of those myths that's been carried on throughout the years, that if you get to do transscleral laser or other forms of cyclophotocoagulation, you're going to induce this early ptysis. I just feel like that has to stop.
May I? I have a brief question about viscodilation. Is it possible that after IOP spikes, the Schlemm's canal collapses back? And if that's so, is it possible to perform again viscodilation?
So surprisingly, we see an ongoing effect of opening up of Schlemm's canal after viscodilation. So what we try now is, and Sheng shows these wonderful pictures with the Anturian OCT, and we're using it now for most of all canal-based procedures, and they show a real opening, and UVM as well, and it's ongoing without a suture. And so the second question was, is it able to do it again? Yes, but the question is it sufficient?
The viscoelastic's gone within a few days, a week, maybe.
Yeah. In a day.
Yeah. But these patients have got to that point of clogging up their canal over 30, 40, 50, 60 years. So it's going to take a while to get that disease back. But will it last 10, 20? Probably not. But yeah, you could go again. Probably, though, if it's not working that well and for that long, you try something else.
Thank you so much.
Just a comment about canaloplasty. The way I look at outflow is just like disease progression. You know, we go from like a reversible phenomena to an irreversible phenomena. You know, and I think canaloplasty, particularly works well before that fibrotic sclerotic TM cannot be rejuvenated. You know, and that's why I think patient selection again is so critical. And I wish is anyone aware of a tool or a biomarker for TM pliability or TM, reversibility? I mean, that would really help us, wouldn't it, to kind of predict what would work? And someone mentioned earlier, where's the resistance? I think Verena mentioned that. So I think we're missing that. And the big piece we're missing in all of this is diagnostics and understanding, biomarkers to predict how people are going to respond. If we have something like that, like, a hysteresis measurement or something like that, it could really perhaps guide us whether we need to canaloplasty, whether we need to remove and strip, or whether we can just maybe stent, right? That may be able to help us in that manner. But I think duration of disease is one marker we know.
Okay, if there's
Come on.
Hysteresis could be a good parameter for comparing the two?
That's a great question. You know, there have been a few studies that have been looking at the corneal hysteresis, which is a measurement of viscoelasticity of the cornea. When you puff, as you know, puff air and you see what the rebound is in that way. To predict, well, medication use, to predict MIGS, to predict bleb surgery. From my read on it, it's not so clear, unfortunately. You know, I think it makes some sense, but that certainly could be something to explore more. Maybe it's a good project to do, whether it's that or Corvus or something like that. I don't know. Anyone else have a thought on that, Joe?
Yeah, I think there's I know a doc who did this, I think one of their AOS thesis on keratoconus and sort of the effect on the lamina. So it is interesting. I do think there definitely is some correlation. It just depends upon, you know, what part of the eye, but definitely, I think we've all operated on some of these eyes that do just seem to have some really atypical scleral rigidity. Probably does correlate to their hysteresis, and I just don't know how to tie all that to the trabecular meshwork. But yeah, I think we all agree, and I agree with Ike. You need some sort of marker. I think age is a big marker. I think we need to look at that. I think we need to really stratify by age, because there's something about, of course, disease severity and, you know, how advanced the disease is, but I think age plays a big role.
SLT works well primary because of probably that reversibility. Last word to Philip.
Yeah, I think that's a really good point. And we've heard recently, actually, at the Moorfields meeting, how prostaglandin use affects the elasticity of the cornea. It may well be the same with the trabecular meshwork. So that we may have to differentiate primary treatment from patients who've been on drops for many years. And these drops, you know, they rot certain parts of the eye, and we have to, I think differently after someone's been on drops for many, many years than for primary treatment.
I think it was, there's one more question?
Just one little question. Am I correct? Did I see that you did the ECP preceding the GDD, or would it be better the other way around? I mean, once you have a GDD which has failed, then go to the ECP. Because if you precede ECP to GDD, that would be able to have some low pressure problems in the post-op with the GDD. I mean, if you reduce the production before putting the GDD inside, would it be better the other way around? I mean, was that correct? What I saw on the flow chart?
If I understand correctly, you're asking about the fact that you've affected the inflow. Does that produce hypotony?
Right.
Well, if you treat early in the disease, no, you have a good inflow. You're reducing the inflow, but actually there's heaps of ciliary epithelium still around, and you're not affecting the outflow unless you do an eye stent or hydrus or some other outflow procedure as well. I'm saying that all forms of cyclodestruction after other forms of drainage surgery potentially are risky, but I think endoscopic cyclophotocoagulation of all of those is the least risky. For example, if you go into a neovascular eye with ECP, you have to be very cautious about treating. I would be, personally, I don't treat neovascular eyes. I know some do, but even those who do treat small amounts, because in that situation, as I think you're intimating, the outflow can be almost non-existent. And therefore, if you crash what little intraocular pressure reduction or production there is left, if you crash that, then yes, you might tend towards hypotony and phthisis. And so I would absolutely agree with that, but I think transscleral is probably higher on my list of potential complications. And I would again reiterate the fact that I've performed DCP on a large number of patients with advanced disease, and as long as you're cautious and I think appropriate with your case selection, I can barely remember a case of hypotony after ECP. I can remember lots after transscleral, but these are often at end-stage advanced eyes.
Well, personally, I think it was a fantastic session.